What else did you find exciting at ESMO? I know we've covered the novel targeted therapies and the ADCs. Anything about the use of ctDNA in this space? We saw the exciting data from the Tombola trial. And I know a lot of people are using ctDNA on a day-to-day basis. Would love to hear what you guys' preferences are.
Yeah, I think it's an exciting time in terms of ctDNA. You know, we have the modern trial as well that is now, you asked the question previously about how to decide about adjuvant therapy, and I think the modern trial will help to answer that question in terms of a risk-adapted approach where patients post-cystectomy are getting randomized if they have a ctDNA positive to nivolumab or the addition of a LAG-3, or if they're negative to observation or adjuvant nivolumab. You know, yes, we saw Tombola and Volga talking about ctDNA. I mean, I'm practically obtaining ctDNA as long as I don't have issues with coverage for patients. But is it really changing what I do? Not yet. I think I'm just adding it as a point of reassurance at this point. But I think with more prospective studies looking at ctDNA, including IMvigor11, we'll be using more and more of it in terms of deciding how to stratify patients.
Anything for you? Are you incorporating it in your?
Yeah, I'm sending it on almost everyone. Again, I'm not really withholding immunotherapy for most patients. I think we're getting close to being able to do that because of these data set that you mentioned at ESMO, but as well as other data sets we've seen. It does seem to be a pretty good risk stratification, so I'm not withholding adjuvant immunotherapy yet. I also am nervous, though, that with the new approval that I foresee coming with Niagara, will these data sets actually come into practice? Because now we might be giving immunotherapy in the neoadjuvant setting. I'm not going to necessarily withhold that adjuvant now that we have an OS benefit. So I think that's complicated. I think it's an emerging space. I think it's ready to be launched into these prospective phase 3 trials so we can finally figure it out. Unfortunately, the next wave of trials aren't really incorporating that either, right? They're still giving perioperative immune therapy as well as potentially perioperative other types of cytotoxics, whether ADCs or chemotherapies. So we're now have all this rich phase 2 data, and unfortunately, our next wave of practice-informing trials are not there to really adapt it. So I think that's unfortunate, but I think we're probably getting close to being able to use it.
Yeah, and I wish that we had that in Canada. We're not there yet.
Yeah,
so in that
fair.
way, you guys are well ahead of us. I think even just collecting that information, getting a bit of a gestalt as how we're going to incorporate will be important. And I think trying to incorporate these into trials will also be really important because you're collecting data fairly rigorously, and including ctDNA there will be really important.
Yeah, and I think the whole question of, because we don't know how much the neoadjuvant immunotherapy is adding to the survival as opposed to adjuvant. You know, if somebody has a PT0 at radical cystectomy, like, do we really need to give them adjuvant? We really don't know the questions, and I think ongoing trials and the data from that will help us.
I think, you know, you were asking about ESMO data sets. I think, you know, one of those things that maybe answers, at least has a hypothesis generating question, is the TERRACE program where they did the muscle invasive, right? You inject this plastic device that folds up in elutes gemcitabine, and then they paired it with cetrelimab, an anti-PD-1 inhibitor, versus cetrelimab alone. And it looks like patients who did not have the full resection of the tissue might have had, with immunotherapy, almost better outcomes. I think that's an interesting thing about, well, if we need, maybe, do we need to give it early? Do we not? I mean, I think these are things that we just don't know yet. But it's certainly fascinating to think about, and it makes sense. If you don't have a lot of cancer cells, is there anything the PD-1 inhibitor can cause your immune system to do? So we've always talked about window of opportunity immunotherapy trials also in other related GU cancers, right? With the neoadjuvant approaches in RCC that didn't quite work out. But I think that's another wave of questions that we can launch that may or may not be, if we don't see the same OS that we're expecting in some of these adjuvant trials, whether they're modern or some of the ones that I've already read out, maybe there is something about giving it earlier.
I think the pretzel device is interesting. That's the
Yeah.
one you're referring to. I think we have to be a little bit cautious, I think, because it does elute gemcitabine locally in the bladder. And we, excuse me, are looking at PCR, but is a PCR with a device that gives drug locally the same as a PCR with neoadjuvant chemotherapy, right? Where there's more systemic absorption of the chemotherapy. So I think time will tell if how those work out. But I think it's exciting, new devices.
Especially in the combination with cetrelimab,
Yeah.
which will add to the systemic therapy. So, so let's say, you know, in the next month or so, we see the approval of gemcitabine durvalumab. Will that be your go-to standard of care for anybody cisplatin eligible, but with the loosened criteria of creatinine clearance?
I think so.
Yeah.
I think the data is compelling enough. I think, you know, we have the modern trial as well. So I think, you know, it is nice to have this option where I am having a more risk-adapted approach if people do not want to go on trial. So that would be, if they do want to go on trial, they can go forward with the modern trial with the standard of care previously. But I think I'm compelled enough to be offering it.
But would you be comfortable offering a trial using only gemcitabine to a patient if gemcitabine durvalumab is the new standard?
That's a great question. Very difficult question. I don't know. I think I would really have to have kind of a risk-benefit discussion of both. I think another thing just to bring up with durvalumab is there were about, I think 8% of patients in the adjuvant arm that stopped it because of immune-related, or they actually didn't capture immune-related adverse events, but stopped it because of AEs related to durvalumab. So although the AEs in both arms were pretty equivalent, I don't think we're capturing the magnitude of IRAEs long-term for patients, and I think it would be important to have that data when you are having that risk-benefit discussion with patients.
Yeah, so clearly a lot of excitement in this space, and good to see a new checkpoint inhibitor now, which was initially in the metastatic space, make way in the localized space.